I would now like to call upon Dr. Abhishek Shinde to give his presentation on jig-based robots.
Good morning, everyone. So just a repetition, what is the previously speaker about this jig-based or robotics. We all know technology has advanced from Nokia 3302 and this Apple phone. And you have to adapt this as per the Razor's technology adoption curve. You have to adopt the technology, and these are the curve which an early adopter like Dr. Vaidya sir has adopted it, and that's why we are here. So why robotics? We all know 20% of the patient after total knee arthroplasties are still unhappy, and that's why robotics. There are many meta-analysis which shows the robotics has better. The types of robotics which has been covered: active, semi-active robots. These are the different robots which are available in the market. So image-based or image-less. Image-based, you need a CT or scanogram. Image-less, the not needed. Lead time is not required. Pre-operative planning details is not available. So robotic arm attachment is cutting or jig-based. So cutting or jig-based secured on a native bone for bony preparation, and cuts taking using the conventional saw blade. Robotic plan able to verified using the conventional instrumentation, and soft tissue tensioning is assisted and recorded throughout the range of motion automatically. So these are the basic steps of jig-based robotics: registration, bone mapping, plan verification, guided cuts, registration, just a video demonstration of all the different points which has been covered yesterday only. So plan verification, once you verified the plan in extension, in different degree of flexion, 30, 45, 60, 90, 120. So once you verify the plan, then you can take the guided cut, how much amount of the balance you want to, how much amount of the distal resection, proximal resection, how much amount of the flexion, slope and rotation you want to give, and accordingly you can plan and take the guided cuts. So these are the guided cuts. Once the plan verification is done, the jig will automatically come and sit, and then you can just recheck the live cuts value, and once the cut is taken, you can again check it whether the cut was taken properly or not. Revalidation. So once you are happy with distal femur, this is proximal tibia. Again, so once you have done the cut, you can validate it and adjust it accordingly. If you are not happy, you can take the recut as well. So once all cuts are taken, you can put the component and then again revalidate it. So what was planned pre-operatively or intraoperatively rather, you can check on the screen how much amount of the correction you have achieved throughout the range of motion, and how much amount of the valgus mechanical alignment or kinematic alignment, whatever you are preferred. So these are the some of the cases. The valgus knee, yesterday I've already demonstrated it with recurvatum. This is her gait with posterior medial thrust, not able to walk. This was her pre-op deformity, 22 degree of valgus and 16 degree of recurvatum. So this was the plan. Distal lateral resection was almost nil. We kept the 1 degree of varus and 90 degree of the knee is balanced on the medial side. So Then only after putting the trial implant, I was not happy with soft tissue balancing, and then did the lateral capsular release and pie crusting. So this is the final picture. This is her gait at while stitch removal. This is active extension. This is the range of motion. So here, these are the different cases you can do it. Unilateral, bilateral, varus, valgus. This is the at 6 weeks climb stairs, can sit cross leg. Many literature report high accuracy of newly robotically assisted technique of total knee arthroplasty. This is ROSA learning curve is about 6 to 11 cases. Comparative outcomes, anatomic functional implant positioning. This is same. This is registry data from Australian Orthopedic Association of Joint Registry. 35% relative reduction in early revision rate with ROSA knee system. So what I observed is surgeon-centered, efficient, highly accurate and reproducible. Learning curve was initial for 5 cases, early recovery and less duration of hospital stay. Tourniquet time is reduced from 90 to 45. 6 weeks functional results are much better. Both plane accuracy is equally better and no pin track complication. Thank you.